Hello everyone, this is Dr. Stewart. Welcome to Urological Conditions in Pediatrics. We will be discussing common urological complaints in the pediatric population. Please let us know if there are any questions or concerns. Next, we're going to move into discussing urinary tract infections in the pediatric population. As with adults, urinary tract infections in peds can be uncomplicated as well as complicated. Uncomplicated urinary tract infections in the pediatric population usually present with dysuria, frequency, new onset, incontinence. Complicated urinary tract infections are usually seen in pyelonephritis, and these children are sick just as they were with adults. They're wiped out, very fatigued. They'll have the same symptoms as uncomplicated urinary tract infections in that they'll have some dysuria, some frequency, some new onset incontinence maybe. They'll also have some flank pain and a very high fever. Please be mindful that management of both uncomplicated as well as complicated urinary tract infections in pediatrics need to be antibiotics need to be dosed based on weight. So it's important to get an accurate weight on your patients at every visit. And this is just to make sure that they're not overdosed with antibiotics and they're given the appropriate amount. So outpatient management for urinary tract infections can be treated with cefiximine. That is a cephalosporin. It's the preferred choice for urinary tract infections in peds, and it's dosed at 8 milligrams per kilogram a day in 2 divided doses. Bactrim can be used as an alternative antibiotic choice. It can be given and used in children older than 2 months old, so that's important to note as well. One side note with Bactrim is that it does have higher resistance rates in certain parts of Ohio, so be mindful again of certain areas and where you work, whether or not Bactrim is a resistant antibiotic. Febrile urinary tract infections should be treated with 7 to 14 day course of antibiotics. Children older than the age of 2 can be treated with 5 to 7 days. Some non-pharmacological measures that we can be instructing our parents on are to schedule toileting every 2 hours during the day, just to make sure that our little ped friends are going to the bathroom often, that they are wiping front to back if they're little girls. That's really important for hygiene measures, and that we're preventing constipation as well. Also, during the course of the infection, it's really, really important that we are making sure that they stay hydrated because, they don't feel well and they're going to have a decreased appetite. They may not want to eat. They may not want to drink. So make sure that we're educating the parents that it's okay if they don't eat, that's fine, but at least offer them fluids often throughout the day, whether it's, plain water or it's Gatorade, Pedialyte, or popsicles. We really need to be stressing that to prevent dehydration. Patients who have febrile urinary tract infections or have recurrent urinary tract infections should be referred to urology, and that is to make sure that a workup can be done to rule out any structural abnormalities such as vesicoureteral reflux, which we know that's where the kidneys are not emptying the urine down the ureters effectively, so we get a backup of urine refluxing into the kidneys, and that's present in about 30 to 40% of children with febrile UTIs. So we really need to make sure that we're getting these kids into seeing a ped urologist specialist if these things are ongoing, so they can get that workup done. Let's talk about some of the disorders, structural abnormalities and disorders that can occur in pediatrics. Kind of touched on this a couple of times, the vesicoureteral reflux. And what that is it's an abnormal reflux of urine from the bladder to one or both of the kidneys. So, and what I mean by abnormal flow of urine is there's an upward flow of urine from the bladder to the kidneys. So instead of going from the kidneys down to the bladder, it's going from the bladder up. And it's commonly found, the most commonly found urological abnormality. Testing can include several different things, actually. A renal ultrasound, which that gives us an assessment of the urinary tract anatomy, the size and the shape of the kidneys, and the bladder appearance. So basically, that ultrasound will help us identify if there's any hydronephrosis or any swelling of the kidneys, any ureteral cells, which are outpouchings of the ureter, ectopic kidneys, any solitary kidneys, or any renal dysplasia. Another test that is commonly done to rule out reflux is avoiding cystourethrogram, and that assesses specifically for vesicoureteral reflux, for bladder outlet obstruction for ureteral cells or urethral valves. It does require catheterization and some radiation, and it gives you a grade of reflux based on severity on a 1 to 5 scale. A DMSA renal scan is also something that can be done to rule out vesicoureteral reflux, and that looks at the renal cortical areas of the kidney to evaluate for defects. A natal hydronephrosis, this is rare. It occurs in about 1 to 5% of pregnancies, and it's a swelling of one or both kidneys detected on prenatal ultrasound. Sometimes it resolves before birth, sometimes it doesn't. So the recommendations recommend that you get a postnatal renal ultrasound to make sure that that has resolved within the first week of life. Multicystic dysplastic kidney, that is a congenital maldevelopment in which the renal cortex is replaced with numerous cysts. Those cysts can be different sizes, and it can be anchored to the parenchyma of the kidney, which is basically the meat portion of the kidney, and it can resemble a bunch of clustered grapes. And there's no drainage of the renal calyces. It's unilateral. Bilateral multicystic dysplastic kidney is not compatible with life, so it's always going to be on one side. And there is an increased risk of abnormalities in contralateral function of that kidney that's affected. So if you're finding any of these things that we discussed, if there's any concern for any of these things that are discussed, then the first thing that I would recommend doing is getting a renal ultrasound just to make sure that there's no hydronephrosis or abnormalities of the kidneys, and then doing a referral to urology so that we can determine the result of that renal ultrasound and determine what workup we need to do from there. Moving on to incontinence in pediatrics, let's start with the subjective assessment. Neurological or anatomic dysfunction. Is there anything neurologically wrong with the child? Do they have cerebral palsy? Do they have MS? Or something of the like? Is there any anatomic abnormalities that's going on? Are they incontinent at night, during the day, or both? Just remember that it is normal for children to have daytime bladder control develops first, and then usually the nighttime bladder control takes many years after that, additional years following, for them to control their bladder at night. So nighttime accidents can be normal, but if they're having chronic enuresis where they're wetting the bed every night and revert back to that after it's already been learned, then that might be a red flag. These children might have some frequency, urgency, dysuria, some interruptions in their stream. They might be holding themselves and moving and squiggling around and trying to strain to get their urine out. They might have associated bowel dysfunction, so constipation might be something. Might want to think about, is there, underlying diabetes that could be causing this? Are they having polydipsia or excessive fluid intake? Your objective assessment is going to be the same as adults. You're going to do an external exam, make sure there's no external abnormalities of the genitalia. You're also going to do a urine dipstick and make sure that there's no infection, any protein, or any abnormal glucose levels. Now let's move on to discussing management of incontinence in the pediatric population. You want to make sure that you're optimizing their bowel habits. We've touched on this before, making sure that there's no excessive constipation, that they're well hydrated, that they're having, fruits, vegetables, high fiber diets to make sure that their bowels are moving, that you're offering frequent toileting to allow for them to empty their bladder often and not have those accidents before they get too full. You want to make sure that you're limiting their caffeine intake. So if they're soda drinkers or like a lot of pop or things like that, or they consume a lot of citrusy drinks, like I don't know if Sunny D is still around, but that was kind of the big thing when I was growing up. So making sure that you're limiting the citrusy drinks and also the acidic foods that they consume. All of those are bladder irritants and can worsen their urinary symptoms. Monosymptomatic enuresis is a condition that can occur after the age of 6. And what that is it's a heterogeneous condition that has several different factors that make it up, including nocturnal polyuria, sleep disturbances, reduced bladder capacity or bladder dysfunction, and sometimes you can even have upper airway obstruction associated with it. Diagnosis of monosymptomatic enuresis includes basically history and physical examination. So we want to make sure that we're evaluating patients for this. It is associated with nocturnal polyuria. So there's a fine line between both of them, and they can overlap in the things that patients present with. So if you do find that patients are having other symptoms associated with the nocturnal enuresis, such as, like I said, the sleep disturbances, the reduced bladder capacity, the upper airway obstruction, then make a referral to a urologist or have the patient's family follow up with their pediatrician to rule that out. Treatment for monosymptomatic enuresis is alarm therapy, and that's basically where the child wears an alarm unit that alerts them that they need to go to the restroom. They also can be given desmopressin, which is DDAVP, and it's dosed at 0.2 to 0.6 milligrams, and it's given 30 to 60 minutes before bedtime. That medication is supposed to help alleviate nocturnal enuresis or bedwetting. A side note for desmopressin is that it can cause hyponatremia, so you want to make sure that you're mindful of that and keeping track of BMP levels to make sure that their electrolytes, specifically their sodium level, is not getting off track. Again, please don't be afraid to refer patients to specialists if you suspect anything that is abnormal, or you feel like the patient is not improving or getting worse. If you suspect any neurology issues that could be the cause of their incontinence, of course send them to a neurologist, nephrologist if there's issues with persistent proteinuria, or if they're having peripheral edema or associated hypertension. Nephrology would be the best bet. And again, if they're having persistent incontinence despite the desmopressin, or febrile urinary tract infections, recurrent urinary tract infections, then urology is going to be the best referral for that. I want to talk a moment about hematuria in the pediatric population. It is going to be a little bit different than the hematuria workup that's seen and performed in adults. So, if you have a child who comes into the office and they have a positive dipstick for blood, you want to make sure that you're confirming true hematuria exists with a microscopic examination. And that's the same with adults as well. But the difference is with adults, hematuria is defined as greater than 3 or more red blood cells per high power field. In children, it's going to be defined as greater than 5 red blood cells per high power field. So if you have 5 to 10 red blood cells per high power field, then that does confirm hematuria in children. And that is confirmed again on urine microscope. Now, both benign and serious conditions can cause microscopic hematuria in children. The most common causes of persistent microhematuria, and this is greater than 6 months, are immunoglobulin A or IgA nephropathy, and then thin basement membrane disease. Some less common causes of microscopic hematuria in children are hereditary nephritis, also known as Alport syndrome, hypercalciuria, urinary tract infections, and nutcracker syndrome. So when you're, treating these children who have or finding hematuria in children in the office, you want to make sure that you're referring to a urologist if disease is suspected. So if you find a mass on an ultrasound, or they have hydronephrosis or kidney stones, if you were to do an ultrasound, then you need to make sure that you're referring to a urologist. If patients are suspected to have kidney disease as a cause for their hematuria, then nephrology is going to be the best referral. And just a side note that cystoscopy evaluation on children with hematuria is very rare, so it's not typically done. Cryptorchidism, which is undescended testicles in the pediatric population in males, can occur in about 3% of newborn full-term males, and it occurs about 30% in premature males. By the age of 3 months, generally 75% of the cryptorchidism cases are resolved because they spontaneously descend by that 3rd month. Now, by the age of 1, 99% of undescended testicles should be descended by then. Males who have cryptorchidism do have an increased risk of infertility and also testicular cancer, inguinal hernias, and testicular torsion are all complications that can result from prolonged cryptorchidism. So if they're repaired by the age of 13, usually that risk is reduced. Now, there is such a thing as having a retractile testicle versus the true undescended testicle or the cryptorchidism. A retractile testicle means that the testicle is up in the inguinal canal of the scrotum, but it can be brought down to the dependent portion of the scrotum. No surgery is needed for a retractile testicle, and they usually descend between 6 to 12 months of age. A true undescended testicle cannot be brought down, and a urology referral needs to occur by 4 to 6 months, 1 year at the absolute latest, and earlier if there's any abnormal sexual development or hypospadias. Hypospadias means that the urethral meatus is located on the ventral aspect of the penis, so that's the underside of the penis. Our pediatric patients might have a slight ventral curvature in addition to the hypospadias, and they might have an abnormal dorsal hood or flap of the foreskin as well. So management for patients who have hypospadias is we are delaying their circumcision. We're not doing that immediately. And we are considering surgical repair at about 6 months of life. And the extra foreskin could potentially be used as a graft of repairing the hypospadias. If the hypospadias is significant, the patient may need replacement with androgen to help facilitate the growth of the penis prior to surgery. They also may require multiple surgeries for surgical correction of the hypospadias, but these kids should be referred to a pediatric urologist for evaluation and management of this. Now let's move on to foreskin problems that are common in the pediatric population. Following a circumcision, needle stenosis is a common condition that can occur. It's rare in uncircumcised boys, and it's thought to develop from irritation of the newly exposed meatus, which usually occurs at the ventral lip. So if you're noticing that there's some narrowing, a pinpoint meatal opening, definitely refer to a urologist for a possible meateotomy for that. Excessive skin, that's when too much penile skin, shaft skin can be removed. In most cases, conservative treatment is the management, which usually wet to dry dressings or antibiotic ointment dressings are the treatment. In severe cases, a referral will be needed and necessary to a urologist. Phimosis, again, we talked about that in the adult population. That's when there's tight foreskin which cannot be pulled back over the head of the penis. It often goes away in children with regular gentle retraction. If the child does develop bleeding, infection, or pain with urination, refer to a urologist for that. Paraphimosis, remember, is a urological emergency, and that's where retracted foreskin of an uncircumcised penis cannot be pulled back into its normal position. So prolonged paraphimosis can compromise the vascular blood flow to the glans penis, and reduction of the foreskin is necessary immediately by a specialist. So you'll want to make sure that they get prompt evaluation for that. Balanitis is a common infection of the penis, and it's inflammation of the foreskin in the glans penis. It's common in uncircumcised children. They can have pain, erythema, and discharge under the foreskin. And it's really important to educate on penile hygiene, making sure that the parents know to pull back the foreskin daily, making sure they're washing that area with soap and water every single day to prevent balanitis. Treatment for balanitis is an antifungal cream topically. Zipper injury is not very common in prepubertal boys, but it's when the foreskin, believe it or not, is entrapped in the zipper. And the treatment for this would be to remove that entrapped foreskin from the zipper as soon as possible. And analgesics will probably be necessary for that. Hair tourniquet is when there is swelling or ischemia of the genitalia by a tight hair thread, and it can occur in infants who are breastfeeding and where their mother is losing a lot of their hair, so the hair falls onto their fingers, their genitalia, and winds up, in a knot and can strangulate things. Diagnosis is made on exam, The management depends on the extent of the tissue damage and also the depth of the fiber or hair. Minor adhesions are common after circumcisions, and they consist of tiny fusions between the foreskin and the corona of the penis. Usually they resolve in time. If parents prefer more rapid resolution, they can do gentle retraction to lyse the adhesions, followed by application of an antibiotic ointment or betamethasone cream low dose at 0.05% can be applied topically in patients with phimosis with adhesions. Minor adhesions can also be prevented with retracting the foreskin 1 to 2 days post-circ and cleaning that area well with warm soap and water as well. Our last topic that we're going to discuss are female genitalia concerns in the pediatric population. Female pediatric patients might experience some interlabial masses that can occur in the urethral area, the periurethral area, or the vaginal area. If you notice any type of abnormality, type of mass in those areas, you want to make sure that you're referring to pediatric urology for evaluation of that. Labial adhesions can be treated with estrogen cream topically for 6 weeks and gentle separation daily, just as it was with the males with pulling back the foreskin daily with warm soap and water. But in females, you can use estrogen cream daily. With the estrogen cream, you might have some absorption and it might cause some breast development. So that's something important to keep in mind with that. And it's treated if the urinary stream is diverted or if the vaginal area is in fact trapping the urine. Vulvaitis is inflammation of the vulva, and that can occur from contact from soaps, detergents, sweat. So you want to make sure that you're educating the patient's family and parents to avoid tights, leotards, prolonged wet bathing suits. They're not wearing cotton underwear. You want to make sure that you're doing an exam for fungal infections, any pinworms that might like to grow in dark, warm areas, and you can prescribe low-dose hydrocortisone cream for treatment of that. So this concludes our pediatric lecture. If you have any questions or concerns, please feel free to reach out to any of us for clarification, and as always, we are happy to do that for you, and I hope you have a wonderful day. Thank you.